Hi, my name is Kevin Demosio, and I'm a third-year PT PhD candidate studying in rehab science at McMaster University under the supervision of Dr. Ada Tang. Today, I'll be presenting findings from my study, It's Never Too Late to Enroll, Cardiorespiratory Fitness Benefits of Long-Term Cardiac Rehab. You'll notice that I've added this maroon bar on the screen so that you can move our faces and utilize the full screen function. Cardiovascular disease, or CVD, is the leading cause of death globally. CVD and related comorbidities, including hypertension, atherosclerosis, and diabetes, cost the economy roughly $200 billion annually. Unfortunately, there are many important sex differences to consider in a CVD time course. Males typically develop a slow onset of CVD earlier in the life course, roughly during the third decade of life. In contrast, females develop CVD roughly 2 decades later, which results in a quicker onset and progression of CVD. And as a result, there is a greater proportion of females living with CVD later on in life. Luckily, cardiac rehab is effective for lowering the risk of CVD-related morbidities, recurrent hospitalizations, and reduces the risk of all-cause mortality. In general, there are 4 phases of cardiac rehab, and the first 3 are typically short-term cardiac rehab programs. These programs are focused around regaining mobility, assessing risk factors, and providing healthy active lifestyle support. The exercise intensity starts off very low in the acute phase, but the exercise prescription becomes more progressive and formalized throughout the outpatient phase. Research has shown that these short-term programs can improve cardiorespiratory fitness and improve other markers of cardiovascular health, including blood pressure and lipid levels. Now, after short-term programs are finished, it is recommended that individuals continue through long-term maintenance phase programs. Now, the body of literature here is limited, but there is evidence suggesting improvements in cardiorespiratory fitness up to 3 years in males following long-term rehab, demonstrating that these programs are effective at improving cardiovascular health. Which brings me to this question. Are delays a cause for concern? Best practice guidelines suggest that cardiac rehab should begin within 21 days after cardiac event. But in reality, most people face delays up to 150 days from hospital discharge to cardiac rehab commencement. Unfortunately, these delays are associated with reduced gains in fitness, less improvements in cardiovascular risk factors, including blood pressure, lipid levels, and body mass, and poor attendance in short-term programs. And unfortunately, there are important sex differences in referrals. Females are less likely to be referred, enroll, and adhere to cardiac rehab programs in comparison to males. What about delayed enrollment in long-term maintenance phase programs? Previous research from our group examined the effective enrollment delay on cardiorespiratory fitness following long-term cardiac rehab. To orient you to this graph, on the y-axis we have maximum METs, and on the x-axis we have time point, so baseline in 18 months. And as we can see, both early and late enrollers improve in cardiorespiratory fitness following 18 months of cardiac rehab, but that early enrollers improve to a greater extent. However, this study did not disaggregate the results by sex, and the follow-up period was only limited to 12 months of long-term cardiac rehab. Which brings me to my purpose statement. To examine the association of enrollment delay on the VO2 peak trajectory over time in maintenance phase cardiac rehab in males and females. We hypothesize that early enrollment will be associated with greater improvements in VO2 peak over time in males and females. We conducted a retrospective analysis of cardiac rehabilitation data from the Physical Activity Center of Excellence at McMaster University. Participants were encouraged to perform aerobic and resistance exercise 2 days per week at moderate intensities. Participants were also encouraged to exercise independently 3 times per week. However, this was not monitored or recorded throughout the program. In order to be included in this retrospective analysis, participants had to be 18 years of age or older, enrolled in long-term cardiac rehab for at least 12 months, which extends the previous study, had dates from cardiac event to program entry, completed at least 2 cardiopulmonary exercise tests with valid VO2 peak data, which is the primary outcome of this study. In total, out of 599 member files, 183 participants were included in this retrospective analysis, including 151 males and 32 females. The following table provides some key participant characteristics and results disaggregated by sex. On average, participants were around 64 years old, were enrolled for around 6.5 years of long-term cardiac rehab, and had a mean enrollment delay of about 1.5 years. In addition, we also found that females had significantly lower baseline VO2 peak values compared to males, which is consistent in the CVD literature. In the male model, we found that a random intercept and random slope model with a polynomial years squared term best represented our data. And contrary to our hypothesis, we did not find an interaction between enrollment delay and enrollment time. Interestingly, we did find an interaction between baseline age and enrollment and baseline VO2 peak and enrollment. For visual purposes, I plotted the interaction between enrollment delay and enrollment time among 151 males with 524 observations. The black circles represent early enrollment and the open diamonds represent late enrollment. And on the y-axis, we have peak oxygen uptake, and on the x-axis, we have enrollment time in years. Here, we see that both early and late enrollers have similar trajectories over time. And both trajectories demonstrate improvements in cardiorespiratory fitness up to 2 years, with clinically significant improvements seen between year 0 and year 1. And then both trajectories decline similarly up to year 5. In the female model, we found out a random intercept with linear years term best represented our data. And contrary to our hypothesis, we did not find an interaction between enrollment delay and enrollment time. Again, for visual purposes, I've plotted the interaction between enrollment delay and enrollment time among 32 females with 107 observations. The black circles represent early enrollment and the open diamonds represent late enrollment. On the y-axis, we have peak oxygen uptake, and on the x-axis, we have enrollment time in years. Here we see that both early and late enrollers have similar trajectories over time. Both demonstrate linear improvements in VO2 peak throughout the entire enrollment time, with predicted clinically significant improvements in VO2 peak of 1.3 and 1.6 milliliters per kilogram per minute in early and late female enrollers respectively. In summary, we found that improvements in cardiorespiratory fitness are possible in long-term cardiac rehab despite possible delays in enrollment. This finding is in contrast to our hypothesis and the body of literature in short-term cardiac rehab programs. Now, there are a few potential reasons why we see a nonlinear decline in fitness among males and linear improvements in females. In males, a loss of testosterone production throughout aging is responsible for several changes, including progressive loss of muscle mass, strength, and cardiorespiratory fitness. They also experience earlier onset of endothelial dysfunction, arterial stiffening, and cardiovascular disease. Females experience cardiovascular disease later on in the life course, typically during the menopausal years. And as a result of the protective effects of estrogen on the cardiovascular system, females experience a later onset of endothelial dysfunction and arterial stiffening. Some research suggests that they also experience less decline in VO2 max, likely as a result of less age-related decline in cardiac output and greater peripheral oxygen extraction. In addition, some evidence also suggests that women participate in more physical activity during cardiac rehab. Taken together, the longitudinal linear improvements in cardiorespiratory fitness over 5 years observed in our sample is highly novel and clinically relevant given the paucity of research conducted to date among females in cardiac rehab. I would like to thank all my co-authors for the support of this work, Paul Stratford for his guidance with the statistical analyses, and the PACE staff, specifically Angelica McQuarrie, and the participants, as this work wouldn't be possible without you. Thank you. If you have any questions, don't hesitate to contact me via email or by social media on Facebook, Twitter, or Instagram. Thank you.